Okay, good afternoon, everybody, and welcome to our session, which is titled Value-Based Management of Healthcare Organizations. And during this session, which should last about an hour and 15 minutes, we try to address questions such as what does value-based healthcare mean, especially for an organization and on the organizational level. In healthcare organizations, then how to support the implementation of value-based healthcare in healthcare organizations, and then we try to spare quite a bit of time to go through some very interesting case examples on how value-based management principles have been implemented in the healthcare setting. And so we'll start with a quick introduction, so you know who's talking here from Helsinki with you today, and then a little bit of introduction, or to make sure that everybody's on the same page on what we mean by value in healthcare and how we think about the implementation of value-based healthcare in organizations, and then So the most time we'll spend on how to move towards value-based healthcare. So how to deal with the implementation, what issues should be considered, and then try to also give some concrete examples for you on how it can be done. So my name is Riikka-Leena Leskelä, and I currently work as research director at Nordic Healthcare Group, and my background is in industrial engineering and management. But for the past 10 years or so, I've now been working on applying industrial engineering principles in the healthcare setting, so healthcare operations research and healthcare systems science, so to speak. And my colleagues here with me are Paulus, Torkki,
hello.
Also a director here at Nordic Healthcare Group, and in addition to that, associate professor at University of Helsinki. Also background in operations research and management, Paulus. And then my other colleague, Pitkänen here, also has a long history of working with us at Nordic Healthcare Group, and she's also a researcher at University of Helsinki, and her research focuses especially on value-based healthcare. And just so you know, our organization a little bit, so Nordic Healthcare Group is a Helsinki-based advisory company specializing in healthcare and social sector, and we're actually originally a university spin-off from Aalto University, but now for 15 years we've been an independent company, and also have offices in Turku here in Finland, and then Denmark, Copenhagen, and Stockholm. And we are actually a certified implementation partner of EHMA.
Okay, before we start, we could shortly think of what means value-based healthcare for us or for me. If you have a piece of paper or laptop where you can write down, how would you define value-based healthcare shortly before we go through the details of the presentation? So I give you 20 to 30 seconds time to think, but this is only for your eyes, so we will come back to that later. Okay, maybe we can go ahead. I know it's not easy because it's a large concept, or how would you define it, but just to get focus on the issue we are considering today. I will go quickly of these basic definitions, because we have had sessions and lectures about value-based healthcare, but what we mean, and in this presentation how we see the value-based healthcare, it's a lot based on Michael Porter's work and definitions. So the value means patient-relevant outcomes divided by the costs needed to achieve these outcomes. We know that there's a lot of discussion as we are in a cross-disciplinary environment, that how the value has been defined in different streams of literature, but this is the the basis of this presentation. So we understand the value here defined by patient-relevant outcomes and costs. And this is the operations management point of view, how the different terms can be seen in a, of course we know healthcare system is a complex system, but this is kind of simplified model. So healthcare system produces outputs like surgical procedures or medication or inpatient episodes or examinations, and the outputs may have positive outcomes which gives value for the patients, and then when we evaluate the value of the system, it's very close to cost effectiveness in health economics literature. And how we can measure outcomes, of course there are different ways to classify the outcomes measurement. There are international frameworks like COMET, Core Outcome Sets for effectiveness measurement. One way is also to divide by the data source. So where is the outcomes information coming from? So it can be divided basically to 3 different sources. So we have patient-reported outcome measures, different kind of surveys, quality of life, so on. Then in some fields, it may be very valuable to use clinician or professional reported outcomes. So when it needs combination of different kind of information and kind of making an overall assessment of the outcomes, so then it may be useful to use clinician or other professional reported outcomes. And then of course we have the various diagnostic tests, clinical information, functioning tests, which can also be used for estimating the outcomes of different outputs. But this is the classification made by data sources, and there are different ways to classify the outcomes information. But this is the basis, so I hope you understand our point of view now that when we talk about value-based healthcare outcomes and so on, so what are we meaning of these issues? Then a question to you. There was an interesting presentation considering this issue by Mirella earlier today, but how do you see the relationship between quality and effectiveness? There has been a discussion. So now you should see a poll in your screen and you can quickly answer that. How do you see this question? Okay, it looks like most of you had an answer, and as we see, this is not clear question, and that was what we were expecting, that different people from different backgrounds can see these concepts a bit different way. So we can illustrate the question once again. So yeah, in some classifications you can think that effectiveness is a or it's a part of good quality, or good quality is needed for effectiveness, or they can even be seen as different concepts. And that's also important to take into account when using these concepts, that we always have to define what we are meaning, because people from different background can understand different things in various way. Okay, but then we are going to the topic of this day. So how can we build and manage value-based system? Now we have a technical issue. Okay.
Okay, but maybe like this.
Okay. So what we have what we have noticed in many projects implementing or trying to get value-based healthcare started in organizations, so it requires both top-down and bottom-up approach. Okay, it's okay now. So you have to have a kind of vision in your organization, be it hospital or healthcare district or primary care center, but you have to define the objectives, the vision and objectives, and you have to support the value-based approach in various ways. But at the same time, it's important because it's still also there have been discussions many years, but we have only a couple of organizations who are systematically using value-based, and we still have a lot of areas, patient groups, specialties where the experiences are limited. So that's why it's important at the same time start small. So start doing, start measuring, start piloting. But if we don't do these both approaches at the same time, there are risks that it cannot be implemented in a sustainable way. So if you just do a visions, do it in a strategic level, then it may be difficult to implement in a practice. But if you only start small doing pilots, and you don't have a vision how to leverage the value-based activities in your organization, then there's a high risk that it's only a project, it's only a pilot, and you cannot utilize the results in other areas. I will go through this first part, so this strategic level and what are the things we have to think and do when we try to support the implementation of value-based approach in organization. And later on, Laura will talk about this start small part, so what kind of activities can be done to implement. So we have to think what is our vision. This may sound a bit also funny, but what do we mean by this is that also we have defined concepts, we have international frameworks. The goal, what are our outcomes, most important outcomes, what are our objectives, it cannot be defined outside the organization. So always when we are measuring outcomes or trying to improve outcomes and value, we have to define the measurable objectives, because there are hundreds or thousands of measures we can measure. Earlier we saw this 3 dimensions, patient-reported outcomes, clinician-reported or clinical tests. We have a lot of possible relevant information for outcomes and effectiveness, but we have to do a vision, define the objectives, which measures are we using, and what are the levels we try to achieve. Of course, it's very important to have all the relevant stakeholders in that discussion, especially the patients. And we have to think who are our key patients, which one are the biggest patient groups, and taking the whole case mix into account. And then what is the value we can provide them. So this is many times the problem, that we don't define the objectives in a measurable way. and then it is very difficult to build up the measurement system for the organization. So we may have tens or hundreds of measures, different measures, but we cannot really see if we are achieving improvements. Okay, then when we have defined the objectives, it is very important to make sure that we can go through all levels of the management process. So how we can implement the strategy as goals for the units, how we can define the metrics to make sure that we are achieving those goals, and how the metrics lead to actions. And this triangle in reality describes what we have seen in many organizations, that in strategic level everything looks good. Many organizations have a strategy like we will be the #1 in our country or in the world in value-based care or in outcomes or patient satisfaction or things like that. But then when we are checking the measures, what are the units in that organization measuring in practice? There may be outputs like number of visits or number of inpatient episodes or costs or some quality measures, but it's not often implemented well enough, the strategic objectives, so that we can build the link between practical measures with the strategic objectives. And that's why it's very important to make sure that when we have defined the objectives, how can we make it reality by defining goals, metrics, and actions for different units, and turn the system a bit more towards value-based. Okay, then a question to you again. So, how do you see the most important benefit of collaborating with other units when piloting outcomes measurement? Okay, looks interesting, and that is very important point, that learning from each others looks like is the very important things, and also comparing the results. And then when we are talking the value-based healthcare, the benchmarking is and collaboration is very important thing, because as we know, all the outcome measures give relative values. So it's very difficult to define that what is a good level, what is the outcome level, without having any comparable information from other units. So in implementing the value-based approach, it's always good to have comparable units to cooperate with. It may have many dimensions or many benefits to collaborate. One important thing is that although we were saying that defining of objectives is very important, but it doesn't mean that we have to develop our own measures, because there are a lot of validated, internationally validated measures and metrics for almost all significant patient groups, but also kind of overall health related quality of life and so on. So to enable benchmarking, it is important to also think that what kind of measures should we use or metrics should we use to enable comparability, international comparability of the results. Because if you cannot compare the results with other units, it's very difficult to know the levels and then to define what is acceptable level, what can be achieved in different areas. But also the cooperation is important for learning from each other, as this is still quite a new field. in many countries. The last point of this, I think, big part is to the customer segmentation or patient segmentation. And this is very crucial thing when we are going into practice, because the outcomes and the value, it is most relevant at the single patient level. So what is relevant for me, what is relevant for you in your case when you have these symptoms and this disease and so on. Of course, it's impossible to build the measurement system based on only individual level information. We have to do some kind of grouping or aggregation of data. But one approach is to think that what is the logic or expected outcomes in our different patient groups. This is an example of our publication in progress. We have already published it in Finnish, but how, as an example of the population can be segmented based on the expected outcomes. And why this is so important, we have illustrated here that we have different ways to define the objectives, but also the whole measurement logic depending on the patient's health problem and what is the logic in that. So we are here describing two kind of typical cases. So the first one is when patient has a health problem which is curative. So then we can expect in most of the cases that the objective can be achieving the same health status as we had before the disease or accident. But then, of course, more and more patients have chronic problems, and the lower example is describing that we can make some kind of forecasts if nothing is done. So the health status, we cannot improve the health status. We can try to maintain the health status good as long as possible, but the measurement logic is totally different. So we don't have before after measurement logic, but we have to follow up the relevant outcomes, and we may have to build the measurement system, for example, annually to evaluate how these patient groups have been the outcomes in these patient groups have been developed. But this is very important to do some kind of segmentation so that we can make sure that the outcomes we are measuring are relevant for the patients. So we define the patient segment so that we can have enough homogeneity to measure for relevant outcomes and how to build the measurement logic for them. But at the same time, we can more easily utilize the information for management and planning purposes for the whole population or the total or the all patient groups we are treating in our unit. So this is the we even see the most difficult thing when implementing the value-based care in a system level or in an organization level, that we make sure that our measurements are relevant for the patients, so for specific patient groups, but we can utilize the information in a system level or organization level, so we can kind of see the big picture from the information we get from different segments. And that's why there cannot be kind of generic classification, or it can be only a basis for the organization specific segmentation, because it depends on volumes, patient groups, the case mix, and many variables, how you have to do it inside your system when you start measuring and following the outcomes. Okay, but now we will go forward to this measuring actions, and Laura will continue.
Yes, thank you. So indeed, we will now talk a little bit about how we can, in practice, start actually measuring, and all the kind of things we need to consider, decisions we need to make before we can actually start measuring. But before we go further, we have another poll. Can you, Sabri, launch the poll? So we'd like to know what you think is the most important way of motivating patients to fill in the PROM questionnaires. If you have experience with that, or if you don't, just how you would think what might be the most important one. Of course, these can all be done at the same time, but just if you can think of one that would be more important than the others. Okay, great. This is very interesting. So the clear winner seems to be patients getting to see their own results and development, which, yeah, I think quite many experiences from the real world and also some studies actually confirm the same thing. Then to continue from where Paulus left off, once we have segmented our population, when we want to start measuring, maybe start the first pilot in measuring outcomes, first we need to choose a segment that we want to start with. And there can be many different kind of criteria for choosing the first segment. For example, the size of the segment in terms of patient volume or in terms of total costs. One thing that we quite often see happening is this point F here, so buy-in of personnel. So if there's a particular specialty where doctors and nurses are particularly interested in value-based healthcare, then that is often a good place to start, because obviously you need quite a lot of buy-in, especially when you're just starting out with something like value-based healthcare, which is still quite new. But these are some of the criteria to consider when choosing the segment you want to start with. And then next, we need to define our goals in even more detail than what we already did, as Paulus was saying about the strategic level. So now we are actually planning the measuring of the outcomes. Like Paulus said earlier, it's good to start with some kind of standard set, like ICHOM or similar. But even if you do, it doesn't really give you all the answers. You still need to think about many things, like which patients to include and so on. At least ICHOM standard sets usually include, they include this inclusion and exclusion criteria, but you still have to go through those and think about whether you, for example, treat all these patients that are listed here, or is it going to be some kind of subgroup that you're dealing with. Then you have to think about what the measuring moments for the PROM questionnaires are going to be, and how are you going to trigger the measuring. Is it always is it the first diagnosis, or is it any time that the patient gets a diagnosis, or any visit that the patient has where the diagnosis is used, and so on. And then just a couple of learnings from practice. We have found that it's good to always keep in mind the whole picture. For example, if we're talking about the hospital, then it's good to think beyond your own segment that you have now chosen for this pilot. It might be good to include some kind of a general quality of life measure, for example, just so that when you have your next pilot and when you leverage into a part of day-to-day work instead of just pilot, then you have some kind of general measure that you can use to compare between patient segments. Another thing is that it's often good to have some kind of measuring moment quite soon after starting. For example, in the picture, there's, I think that's coronary artery disease probably, but there is one measuring moment at 30 days after the entry event. And that's good because then already when you start measuring today, then in 30 days already you have some patients who have answered your questionnaires twice, and you can already make a comparison, already take a look at their outcomes. So just to sort of keep the momentum going, once people are excited, it's good to have data fast rather than just like wait a year and then have the first data. So that's just a sort of general tip that we have learned along the way. But of course, when you're using some kind of standard set, you shouldn't make any significant changes. But obviously, you can add a measuring moment, but you should probably not take away any major measuring moments or things like that. Then you have to think about the technical side as well. So how to collect the data, the PROM data first of all. Are you going to do it digitally or on pen and paper, or maybe both? Are patients going to be filling in the questionnaires on site or at home? Maybe your EMR already supports PROM collection. If it doesn't, then maybe you need some kind of special software for it. Or if you have a lot of, say, well, no one has extra workforce, I guess, but if you have more time than money, let's say, then you can sort of just send the links to the questionnaires by email and so on. So just consider the amount of manual labor that is going to be needed for the data collection. And often that's a trade-off with cost of the software. Then also, as Paulus mentioned earlier, you have in addition to the PROMs, you have the clinical measures. So you need some kind of clinical data on the patients. It's obviously never good if the professionals have to use extra time to input the same data into several different systems. So that is definitely not advisable. What we like to do instead is utilize data from the electronic medical records, or if there's a quality registry, lab data, stuff like that. Any data you already have, try to utilize that as much as possible. And there, a skilled data scientist often saves a lot of trouble and money also. So we would advise to use a data scientist instead of having your physicians doing the analysis in Excel and so on, or gathering the data even. Okay, then you just start measuring. And now we come back to the poll question that we had about motivating the patients to fill in the PROM questionnaires. Some studies have found that it's very important that the data is used so that the patients see that their answers matter, and that they are not asked the same questions again when they come to the office, but rather the physician or nurse takes a look at their questionnaire answers and discusses them. And also, of course, it's probably good to have like a verbally prompt the patients to answer. Tell them they are going to be getting a link via email or however you're going to do it, and ask them to answer, fill in the questionnaires. And one more note about the actual measuring is that you should, of course, not forget about the costs. Or you can also use resource usage measures as a proxy for costs. But I guess the item standard sets are the most often used standard for value measuring, and they don't really say anything about costs, even though cost is obviously important. And also, or I might say especially when you want to benchmark your data, it's obviously nice to benchmark your outcomes to see what is a good level and so on. But if you don't include costs, then especially in different healthcare systems, if you're doing international benchmarking, then you may be not getting the full picture there if you don't have the costs included. And then finally, you need to also utilize the data, turn it into information, because first you just start with some kind of Excel file full of numbers and indicators, data points, and you need to think about how to turn those into meaningful information for the clinicians, especially when you're thinking of sharing the results with all the clinicians, maybe the patients also. Then you have to use your own discretion in turning the data into information. This dashboard is actually from an actual project we have done, but we'll talk a little bit more about that a bit later. And as was mentioned before, when interpreting the outcome measures or the results, the data you get, benchmarking is very important, because without benchmarking you obviously don't know what is good, what is bad, and so on. If you just have the numbers, you don't know if they are good or not, if they're good enough, and so on. And obviously you can do benchmarking on many different levels. You can compare patients to each other. You can share the data to the clinicians, and they can compare peer-to-peer for learning purposes. Then you can compare their teams' units, and so on, national, international comparison. All the levels have a slightly different use, but all useful. So that actually concludes the dogmatic part of our presentation, and now we still have quite nicely some time for the case examples, because we figure those are probably the most interesting to you. So we have 3 case examples here, and after those we'll still have some time for questions and answers. So if you have questions, just type them in the there's a chat or Q&A box, or yeah, either one, I guess. Okay, but before we go more into the case examples, we have another poll. Thank you, Sabri. So many stakeholders can utilize the outcomes information in many different ways. Probably all good and important, but which one do you think is the most important? Again, there's no right answer. This is just to get you thinking, and also because we are curious to know. Okay, looks interesting. Yeah, using the data in day-to-day patient work seems to be quite a clear winner here. Yeah, as I mentioned, no right or wrong answer here, but it's very interesting to see how different people think about this, and probably one's background also has quite a large effect on how one thinks about these things. Okay, but thank you for that, and now let's go into the cases. First of all, we have the case of dental care in the city of Espoo. The city of Espoo wanted to start measuring outcomes, and this was before there was an EHMA oral health standard set. So we together with Espoo and some other cities and municipalities in Finland, we defined measures. They were first piloted in one unit, then expanded all over the city of Espoo, and then later other cities started using the same outcome measures, and they are currently being used by 26 public oral healthcare service providers and one private provider. And Nordic healthcare group does benchmarking on this data. We don't have the results here, but we do have the measures. So this is the set of measures that we landed on. This was, as always, decided together with all the participants of the benchmarking. So the dentists and oral hygienists, and then experts of dental care from Nordic Healthcare Group all work together to come up with these measures. And these are all the kind of data that we can already get from the registries. Now in Finland we have pretty good registries, especially in dental care actually. So we can get all of this from the EMR data. Of course, PROM measures will be added later, but or that is obviously the next step, because that's what's missing. But these clinical outcome measures have been quite useful already. Then another case is from Central Finland Healthcare District. This is another project that NHG has done. We started in 2018 by choosing metrics and so on. So Central Finland Healthcare District wanted to implement EHMA standard set in coronary artery disease. And we decided to start using QuestLink software from Philips Vital Health. So we translated that into Finnish and implemented that, deployed that software, started collecting data in March of 2019, and then at this point we have actually quite a lot of data already, which we have then turned into a dashboard, which I already showed you briefly. This is another part of the project that was largely done by NSG. So what we did together with the client was decide which are the most important outcomes, both PROMs and clinical outcomes, and how to visualize those. So in addition to showing, for example, here you can see the 3 PROM questionnaires. And in addition to showing the situation at the start of the measuring and then at 1 month, we have also added another graph on the right, which shows which percentage of the patients has improved or which has worsened, and whose state is unaltered. So between initial measurement and then 1 month measurement. And that also illustrates my earlier point about having a measuring moment early on. So this was really nice because once we started measuring already at 1 month, we had some data that we could look at and start also building the dashboard so early in the process. And then I guess the next step for Central Finland is making changes in their processes based on this data. We are not quite there yet, but this is a big step forward for measuring outcomes, and especially systematic measuring of PROMs. It hasn't been done that many times in Finland before that. And then over to Riikka with the...
Yeah, so DECIMAL is a case of mostly primary care, but it's sort of a public-private third sector partnership that combines also other services under the same roof. But the idea in the alliance, core alliance between the city of Tampere in the middle of Finland, as well as a private service provider, Mehiläinen, is about primary care outpatient services. And the outcomes measurement is a part of the tendering deal. So the private provider Mehiläinen is paid mostly based on a fixed fee, but 2% of the total annual revenue for the company from this contract is based on outcomes, certain outcomes and measures. Of course, the setting is a bit difficult since many outcomes are not or were not routinely measured. So the set of measurements is something that could be compiled based on the data that was available, and in many cases have to devise some sort of proxies for the actual measures that you would ideally like to measure. But there are some so the measures relate to the well-being of the population. First of all, the well-being of the children and adolescents, and the data for that is based on a well-established school student and surveys that are done nationally in Finland. And then there's the other sort of domain of well-being measures relates to adult population with chronic conditions, and there we do have some clinical outcome measures available that can be used, for instance, in type 2 diabetes or coronary artery disease. But then also thinking of sort of the pathway towards better outcomes, it was seen that also having just a structured treatment plan for each patient would improve the or it would enable better the possibility of outcomes improving if a more personalized and structured and systematic approach to the care would be taken. So that's why also that was as sort of a proxy measure or short-term measure for success. Then for the well-being of the elderly population, the key measures that were included were the functioning of home care customers. So if you are a customer of home care in Finland, there is always a systematic measurement of your at least physical functioning, but in many cases also psychological or mental and or cognitive and social functioning as well. Then as proxies of how well the services work, there was a measure for emergency department use of the elderly, and this was sort of a comparison between this one health center and then the rest of the health centers in the city of Tampere, which were then operated by city of Tampere alone. And also to make sure that the primary care operator does its tasks and does what primary care is supposed to do, and does not try to reduce its own costs by referring everybody to secondary care. Then also the costs of secondary or specialized care, so secondary and tertiary care per population was measured and compared to other districts in the city of Tampere. And then, although not an outcome measure, but also a part of this contract was the measurement of the satisfaction of the different stakeholders. So especially the satisfaction of the patients, so their experience measured by Net Promoter Score, and then a survey of collaborators' satisfaction. So this Alliance has been working for two years now, and the first results are available. So it turned out not all measurements were that easy to calculate, were not available, but most of them were, and that it would appear that the well-being of the children has increased a little bit, but there has been a significant increase in the percentage of patients for whom these systematic care plans have been drafted. But other than that, the changes are not that significant, and also compared to how this Tesoma Health Center is working compared to the other districts in Tampere, there does not seem to be a drastic change. And in the cost of secondary care, there's even an increase in secondary care in the patients and from the area of Tesoma compared to the other districts in the city. And also the customer satisfaction is not high, or it's lower than in the rest of the city. So just, of course, it's very difficult to change things fast, but still, and also then one can question whether this 2% of total reimbursement is incentive enough for the operator to really focus on improving the outcomes. Then, before we conclude, one more poll. So what do you think is the biggest challenge related to implementing value-based healthcare? The most popular answers here seem to be turning data into information and turning information into action. And those are, I think, probably one of my answers would have been, or I would have chosen one of those. It seems to be very difficult to understand what to do with the data and how to turn it into relevant information. and even if you, and that's meaningful for the different stakeholders and reliable, so that people actually believe in it. And then also the question of, well, what then? So what should you do based on that information? And actually that is a good sort of a conclusion also for our talk, is that the most important part is to make use of the information, because it's always costly. So somebody has to do something and spend time on something or invest in something so that you get the data, and usually you have to spend some effort into processing the data into information. So that is all not worth it if you don't use the information for anything. So on the patient level, or it's important to use it on the patient or in interacting with patients, because that also then incentivizes the patients to actually answer the questionnaires if PROMs are part of your outcomes measurement framework. And also that ideally you should be able to utilize that information, or the clinician should be able to utilize that information when making treatment decisions specific to that patient. Then on the professional level, the data can be used for the professional to actually assess and get visibility on the results he or she can achieve with his or her patients. And this is something that can motivate the clinicians very much. But it can also, if the culture in the organization isn't trusting and it's not open, it can also create a lot of friction between the colleagues. And then, but at least our experience has been in some cases that the professionals have been very excited to get visualizations and aggregations on how their patients are doing and how their health status has changed. It also motivates the professionals. Then on the tactical level, so we're talking about so to speak, middle management in hospitals. There again, the information should be used, but for managerial purposes. So either using it when discussing with the professionals in the unit, making how to change, what if they're identifying needs for development in the services, or needs for certain patient groups to be focused more in and that kind of decisions. And then on the strategic level, so hospital level, then you should use the outcomes information in strategic decision making, in resource allocation, and there you should be able to then compare these somehow, the measures also between specialties. So there it's important to have some sort of standard measures. If they are all very disease specific clinical outcome measures, it's impossible to compare or identify potential care needs or gaps in different parts of the hospital if you can't compare the different patient groups by any measure. And also the availability and the time frame of the data changes a little bit. So if you want to use it in the patient interaction level, you have to have it available quite real time, and the professionals need to have access to that information real time, and also effortlessly. So some sort of integration to the professional's view in the electronic medical records system probably is required. Then for the professional level and the tactical unit level, a monthly or annual basis is enough. So you have time to actually maybe manually process some of that data and do some analytics. And then for the strategic level decision making, the time frame is even a bit longer, and relevant data can be gathered from a longer time period. Also, with outcomes, the time frame within which the outcomes materialize after an incident or a treatment also differs a lot between different patient groups. So you have to take that into consideration as well.
Okay, I guess this one we'll save for last, but at this point I think we could have a little questions and answers session. I believe there's quite some comments in the chat actually. Yeah, but I let's see if I can see them here. Also, if someone wants to just raise their hand and just say your comment or ask your question, that is also absolutely fine. But if not, and I cannot see the chat here, so I can. But I think Riikka, you picked some comments from the chat.
Yeah, one comment earlier on in the stream was about value for professionals, and then we also need to keep the professionals happy, which is an interesting viewpoint. And
that was my question. I'm sorry, I cannot host turn down my video, so I cannot put it back on. So it's not that you're not allowed to see me. I already got my head chopped off because of the second point, so let's not go into that. But it was just to get some discussion about what value-based management should be. But the first one, I'm really interested in that because I really see these two trends in thinking about value-based management or healthcare or whatever you want to call it. And we're really forgetting the professionals. And especially when you ask the question, how can you motivate patients to give the data? I think an even more important question is, how do you motivate professionals to change and make the changes that are necessary to get to this best value? So I see a trend that people say, well, you really should take some outcomes from professionals into this value-based healthcare if you want to get good results for everybody. So I just wondered what your intake was on that.
Yeah, that's a very good and essential point of implementation. Maybe we were, of course, always you have a schedule and you have to make choices, what things you can consider and what not. And then now we focus more on technical aspects of the implementation, but that's very crucial in making the value-based culture sustainable in the organization. However, we have seen that I'm not saying that you should not pay attention to motivation of professionals, but from many other kind of development streams, value-based is from that perspective easier to sell to professionals that most of the professionals are interested in outcomes and then outcomes for the patients. So that is not the thing or we have not seen a lot of professionals that say that this is not relevant or we should not go to that direction. But of course it needs change, as you said, that and maybe needs changes in the way of doing and registering of things. Maybe some additional information is needed to evaluate the outcomes and so on. So that's the cultural aspect really needs to be also taken into account. But maybe it needs another workshop to focus really on that side of implementation.
Yeah.
Can I come in here on this one, please? Is that okay?
Sure.
Yeah.
Yep.
Okay. Thanks very much. It's a fascinating thing, and it's really an excellent tool. We in the UK call this population health management, based on segmentation and risk stratification of patients, and it's a fantastic tool for managers. I have absolutely no idea why you call it value-based healthcare. I have to be honest with you. And I would love to hear the views of others in this room, especially Oscar and others who are actually dealing with value-based healthcare. And the reason to hear their opinions, the reason I have real doubts about this is, as Paulus said earlier on, what it gives you is data on population groups, on patient groups. Now, value-based healthcare at the center should at least be person-centered care. And going through your measures, etc., there's hardly any patient-centered measure in there. So I really would love to see. I mean, I'm all for population health management. It's a fantastic tool. I really love it. But as my colleagues in Scotland and elsewhere say, who actually deal with patients every day, the real work, creating patient-centered care, comes after you get the data. The data doesn't tell you anything about individual patients. It tells you something about patient groups. And I would love to see, you know, what the opinion is. Why should that be why should it be value-based healthcare? Because the values are really created only by the difficult decisions on the ground, not by population health management calculations. But I might be wrong. I mean, I'd love to hear your opinion on that.
No, I totally agree with your point, and I understand the question. I'm also, my base unit is Department of Public Health, and maybe what Michael Porter originally wanted to say when defining this as a value-based was that we really start measuring of patient relevant outcomes. So what gives value for the patients? I think that's maybe the origin, but I agree it's very close to health economics, and it's very close to traditional also public health. But I think the value-based, how we see is there are 2 points so compared to the earlier ones. So it's quite practical approach. So measure try to define the outcomes so that they are relevant for the patients. Of course, we hope that for individual patients, but in a system we always have to find the balance that how detailed level can we go. And another important point is make it systematically and everyday life. So not only doing register-based studies or health economics macro level analytics, but try to build the system so that you can utilize this information for organizations. But I agree, and I can see your point that there's always it happens that you call something, you add something to the earlier theories and you give a new name. So that's also why we wanted to show the definitions in the beginning, that this is what we are talking today.
Yeah, and I think there was also a comment that there weren't any patient-centric measures in the dental care list, and that's absolutely right. There weren't any prompts or measures like that available at that point. And I think also what the city of Espoo wanted to do there was more to compare on a population level instead of sort of patient level or patient centric. But I think we are a little bit running out of time. There, I'm sure it would have been nice to discuss more and hear even more of your comments, but we'll at least take all the comments from the chat and think about them. And here is something for you to think about. So now, after this session, how would you now define value-based healthcare? And just for everyone to think to yourselves Did this change your thinking in some way or not? I guess that's it.
Okay, thank you very much. And you can find our information in our presentation, and please contact if for further questions and discussions. This is very important and interesting topic.
Yeah, also on the web page there's our contact information, or at least names, so you can find us on LinkedIn if there's anything that you would like to discuss further. And let's show once more there's the contact info also in case someone
Thank you
is interested.
and see you.
Thank you very much, everybody.